All right, everybody. This is going to be Chapter 15 of our Emergency Medical Responder course. This is going to be injuries to muscles and bones. You guys are going to see a lot of this stuff responding to car accidents. These are also trauma injuries from falls, sports injuries, things of those sorts. And you guys will be responding on quite a few of them before an EMS service with an ambulance can get there. So let's get started. Our introduction. You're going to encounter many types of musculoskeletal injuries. We're going to see fractures, dislocations, sprains and strains, head injuries, spinal cord injuries, chest injuries. We're going to go over our basic anatomy again and how it functions with the musculoskeletal system so we know how to help treat these injuries. We need to be able to recognize signs and symptoms of various musculoskeletal injuries. And providing that proper care at the scene can help prevent additional injury or even disability. As always, we want to follow our patient assessment, starting with our scene size up, standard precautions, keeping ourselves safe. Then we're going to hit our primary assessment, determine any life threats, ABCs. Move on to our history, see if there's anything we need to know before we get moving. Secondary assessment, and then our reassessments. Like I just said, we're going to follow those standard precautions, protect you and the patient from infectious diseases. Do our complete primary, immediately follow with the secondary, get our sample history, and then continue to reassess. So, the skeletal system. We talked about this back in the human body. We've talked about it in a couple other chapters. Obviously, there's some stuff that we need you guys to know about this, so we're going to go over it again just to get a little refresher before we move on. Skeletal system is going to consist of 206 bones. It is the supporting framework of the body. It's going to support the body. Otherwise, we'd just be a pile of flesh on the ground if we didn't have that skeletal system inside there holding us up. Protects all our vital bits and pieces. Assists in our body movement. It also helps manufacture red blood cells inside the bone marrow. Generally, it's divided into 7 areas. We have the head, skull, and face. Our spinal column, that shoulder girdle, upper extremities, the rib cage or thorax, our pelvis, and then our lower extremities. And here we can see that skeletal, those different sections in a diagram, just like we talked about. All right, the bones of the head will include the skull and the lower jawbone. The skull is actually many bones fused together, forms a hollow sphere that contains and protects the brain, and that jawbone is a movable bone attached to the skull. Will complete the structure of the face. Our spine is going to consist of a series of separate bones. They're called vertebrae, if we remember. The primary support structure for the entire body. This is where everything's kind of attached that helps hold our body up. Spine has 5 sections. We need to know these sections. We need to know the order that they go in, starting from the neck down to the tailbone. We got our cervical spine, the thoracic spine, our lumbar, our sacrum, and our coccyx. Here we can see that in the diagram. You can see those first few form the cervical spine. Then we have the thoracic, lumbar, which is in the lower back, sacrum, and then our coccyx or tailbone. Each shoulder girdle supports an arm, and it's going to consist of the collarbone or clavicle and that shoulder blade or scapula. The upper extremities consist of the 3 major bones plus the wrist and hand. So we just talked about shoulder girdle, which is a support for that arm and then we're talking about that upper extremity, which is the arm, and it's going to consist of the three major bones and then all the little bones in the wrist and hand. So main bone, that big bone in our arm, so the humerus, and then we have the forearm with the radius and ulna. That radius and ulna, we need to know which side of the arm it's on. If we remember our radial pulse, where we find that, which is on the thumb side of our arm, that's where our radius is, which means our ulna is on the little finger side. It's important that we remember where those are, okay? Next, we're going to have our 12 sets of ribs. These are going to protect our heart, liver, lungs, spleen. All of the ribs are attached at the spine. Okay? Remember that they're all attached at the spine. They are not all attached on the front side. At those first few ribs, what do we got? 1, 2, 3, 4, 5 that are attached. Each one it's attached to the spine, wraps around, and then attaches to the sternum. Then we have that next set that come from the spine, they come around, and they actually have bits of cartilage which kind of connect them all into one piece, and then it's connected at the sternum. We need to remember that pointed structure at the bottom of the sternum is the xiphoid process. And then down here, you'll see it, our 11th and 12th ribs. These are called floating ribs because they are not attached to the sternum at all. All right, our sixth area of the skeletal system is the pelvis, which links the body and the lower extremities. Our lower extremities consist of the thigh and the leg. So our thigh bone, the femur, that's going to be the longest and strongest bone in our body. And then our leg will consist of the tibia and fibia, plus the bones of the ankle and foot. Generally, all these smaller bones, for us when we're talking about them, we just consider it all one unit. Okay, we don't really need to get into all the different little bones that are down in there. So as long as we just remember that we just talk about that as one whole unit. All right, muscles. Muscles of the body provide the support and movement. So we have all that structure under there with the bones. Those muscles are going to help tie everything together, keep things supported, and allow us to move. We need to remember that muscles are attached to bones by tendons and cause movement by alternatingly contracting or relaxing. Movement occurs in joints where two bones come together. Bones are held together by ligaments. So remember that muscles are attached to bones by tendons. Bones are attached to bones, other bones, by ligaments. All right, we're going to have three types of muscle. Voluntary or skeletal muscle. These are attached to bones and can be contracted and relaxed by a person at will. So we have control over these. We're able to think about moving our arm at the elbow and it'll do it. Okay. Involuntary muscles are smooth muscles which are found generally inside the digestive tract and other internal organs. We have no control over these. These are the muscles that digest our food and then move that waste along the intestinal tract and do other stuff inside our organs. We have no control over that. That's why they're called involuntary. Then we have cardiac muscle, which is only found in the heart and is able to produce electrical impulses to keep that heart beating. Quick diagram of those different types of muscle. Skeletal muscle, which is our voluntary muscle that we have control over. Smooth muscle, which is involuntary, we have no control over. And then the cardiac muscle, which is only found in our heart. All right, so we need to understand mechanism of injury. These are generally the causes of musculoskeletal injuries. We have direct force, indirect force, and twisting force. As you can see in the picture there, direct force is directly where the force was applied. In this one, she has direct force right on her knee. An indirect force would be because she struck her knee on the dashboard there, indirectly it caused injury to her hip. And then we got our skier here. He's twisting his leg outside. That's twisting force. We need to use the information provided by the dispatch to gathered from the scene to identify the possible mechanism of injury. There are many different ways to describe a patient's injuries, and we need to use our senses of sight and touch. We need to listen to what the patient says, and we need to do our job to provide the best assessment and treatment. In talking about that, we need to remember that we're here to treat the patient's injuries. So what we see, what we touch, what they tell us. We can't diagnose everything, and that's not our job. We don't have an x-ray in the field. We don't have CAT scans. We don't have a bunch of other tools that are available at the hospital. So we're going to leave the diagnosing to the doctor, and we're just going to treat what we see and find and are told about. All right, now we're going to talk about some types of injuries. Our first is going to be a fracture. Fracture is a broken bone. Most of us know what this is. Some of us might have actually had one. This occurs when there's a significant force applied against a bone. In a closed fracture, that bone is going to be broken, but contained inside the skin. In an open fracture, the bone is broken, and the overlying skin where that break is lacerated. Might be caused by the bone, might be caused by the external force that was applied there. Don't know. Either way, they're both going to be bleeding, and those open fractures are most likely contaminated with dirt, other bacteria, and this might lead to an infection. This is stuff that needs to get splinted or dressed, splinted, and then get to the hospital so that the doctors can get it taken care of. All right, our dislocations. Dislocation is a disruption that tears the supporting ligaments of the joint. So remember, ligaments connect bone to bone, and when we have a dislocation, those ligaments tear, and then we have the bone ends separate completely from each other. Usually they're going to lock into one position. Any movement of that is going to cause extreme pain and can also damage nerves and blood vessels in the same area. All right, our sprains and strains. A sprain is a joint injury caused by excessive stretching of the supporting ligaments. So we've overextended those ligaments and now we have a sprain. A strain would be stretching or tearing of a muscle. It's important to remember both of those. Sprain is excessive stretching of the ligaments. A strain is a stretching or tearing of the muscle. Signs and symptoms of extremity injuries. For any of these fractures, dislocations, sprains, strains, we're going to see pain at the injury site. An open wound. Remember, we might see some blood. We might see blood. Remember that that's a good place for infection because now everything that's protected by the skin from getting infected is open, and it's a good place for dirt, bacteria, all that good stuff to get in there. We're going to see the patient's inability or unwillingness to move the extremity. Might see deformity or angulation. Angulation would be where, if we're talking about our forearm, it's supposed to be a straight It's supposed to be straight bone there. If it's not straight like it's supposed to be, that's angulation. Also might be tenderness at the injury site. Standard precaution in musculoskeletal injuries. We need to assume that trauma patients have open wounds that pose the threat of infection, and we always need to wear our approved gloves. Anytime we get out of that truck and arrive on a scene, we need to be prepared for the possibility of coming in contact with bodily fluids, so we should always be wearing at least our gloves. If we respond to a motor vehicle crash, remember there's going to be glass, sharp bits of metal, all kinds of stuff out there. So might be a good idea to wear heavy rescue gloves. And if we have active bleeding that might splatter, we should have protection for our eyes, nose, and mouth. We don't want to get any of that nastiness in there. Examination of musculoskeletal injuries. As always, we need to do our general patient assessment first and follow all the steps of the patient assessment process before we do anything for those injured limbs. If we have somebody with a broken arm, but they're not breathing, it does us no good to set that broken arm in place, but then they're not breathing, and so we've just set the broken bone of a dead person. We have to stabilize ABCs first. We have to make sure that they're going to live to appreciate the fact that we set their bone, or that we splinted their bone before we moved them. It does no good for us to do anything if they're not alive, and we're not taking care of those issues, making sure to hit the ABCs and any life threats. The one time we do need to address limb injuries is if there's excessive bleeding that could cause a life threat. If they're bleeding out, we need to treat and take care of that before we can move on to our other ABCs. All right. Examination of the injured limb. We need to inspect the injured limb and compare it to the opposite uninjured limb. To do that, we might have to remove clothing. Now that might be having to cut it off carefully or helping the patient out of their clothing. If you have a motorcycle wreck, this guy's wearing a nice expensive leather jacket, but he just has a broken arm, might want to think about helping him out of that jacket before just cutting it off. Okay, we want to kind of be our patient advocate and make sure that we're doing the right thing. If we have an unresponsive patient and we need to get them out of their clothes quickly, yes, cutting off the clothes would be a good idea. But we need to have some common sense with that. So after we've exposed the injured limb and the opposite uninjured limb, we need to examine it. We might find any of the following: open wound, deformity, swelling, bruising. Tenderness is going to be the best indicator of an underlying fracture, dislocation, or sprain. We're going to start at the top of each limb, and using both hands, we're going to squeeze the entire limb in a systematic, firm manner. If we find any of those deformities, contusions, swelling, bruising, burns, whatever, we need to examine the other side and see if that's, at times, some people are just a bit different than other people, so we need to make sure that it is actually a injury caused by the trauma event that we're at, and not something that they have going on all the time. So we need to be checking both extremities as we're doing this. As we conduct our hands-on examination, we need to ask the patient where it hurts most. The location of the greatest pain is probably the injury site. If the patient shows no sign of injury, then we can ask the patient to move the limb carefully. We really don't want to have them moving their limb, their extremity, until we've gone through and found that there's not really any signs. Okay? With any injury, we may have associated blood vessel or nerve damage, so we need to evaluate the circulation, sensation, and movement of that limb. We need to check the circulation and sensation after any movement of the limb. So if we do any treatments, we splint it, we uh, put it in a sling and swath. Anytime we move that injured limb, we need to be checking for circulation and sensation. There's a drill in your book, chapter 15-1. It's going to check for circulation, sensation, and movement. What it'll go over is we need to check for a pulse. We need to see if there's a pulse distal to the point of injury. That's furthest away from the point of injury. And when I say furthest away, I mean on that same limb. So if we have a broken humerus, we need to make sure that we have a radial pulse. Okay? We're going to check for capillary refill. This is, we should have talked about this before. We squeeze the nail bed, and normally they're nice and pink. We squeeze them, they turn white. The color should return approximately 2 seconds, and this is going to give us a good indication of circulation in that limb. We need to remember that cold environments or other medical conditions that cause poor circulation can have a delayed cap refill time. Okay. Then we also need to check for movement or sensation. Can they feel us touching? So they have that broken humerus again. Can they feel us touching the palm of their hand? Can they feel us squeezing on their finger, the nail bed, to check for cap refill? You know, we need to make sure that they have all three of those: the pulse, sensory, and circulation in their extremity. And once again, that's something that we do at the very beginning of our assessment as we're assessing those injuries. We also need to assess it after we've moved it, after we've splinted it, and when we're loading them into the truck and getting them going, we need to make sure that they still have all those sensations and PMS to make sure that nothing has happened. All right. Treatment. All limb injuries are treated the same way in the field. We're going to cover the open wounds with dry, sterile dressings. Apply firm but gentle pressure to control bleeding. Cold pack to painful, swollen, or deformed extremities. And we're going to splint that injured limb. All right, so some general principles about splinting. Advantages: it's going to prevent the movement of broken bone ends, a dislocated joint, or damaged soft tissues. We don't want to, we got that broken bone end, we don't want it be moving it so much that it was a closed fracture, but now that we've moved it, we've managed to cut through and we now have an open fracture. So we need to stabilize that, and what we're going to do is splint it to keep it from moving. This will also help control bleeding. Like I said, it'll decrease the risk of additional damage, so we're not making things worse, and prevent closed fractures from becoming open fractures. We're going to use common sense when removing clothing from the injured limb to inspect for open wounds, deformities, swelling, bruising, cap refill. We're going to note and record the pulse, the cap refill, sensation, and movement distal to the point of injury. It is recommended if you have injuries to the leg and you can find that pulse in the foot. Generally, we'll take our pen or marker and mark on the foot where we found that pulse so that we can quickly go back and check it again. We're going to cover all our open wounds with a dry, sterile dressing before applying the splint. We need to remember that we should only move the patient if there's an immediate danger. So if we're on the icy highway on the other side of a hill, nobody can see us on that other side, it might be prudent to move them fairly quickly or get somebody blocking traffic behind us. Or if we're on a job site and there's a danger that could be imminent, we need to only move them in those cases. When we do splint it, we're going to mobilize the joint above. So we're going to immobilize the joint above and the joint below the injury site. So on that humerus fracture that we've been talking about, we want to immobilize the shoulder joint and the elbow joint. We don't want those to move. If we use a rigid splint, we want to make sure to pad it so that there's no voids and it's in the most comfortable position for the patient. And we want to support the injury site and minimize any movement of the limb until the splinting is completed. We want to splint it without moving it unnecessarily, and when in doubt, go ahead and splint it. We can always remove them. So some of the different types of splints we use, we have rigid splints. These are made from firm material. They're applied to the sides, front, or back of an injured extremity. Some of the common ones are padded board splints, molded plastic or aluminum splints, padded wire splints, SAM splints, folded cardboard splints. Here's a couple pictures. That's a foldable cardboard splint on the left-hand side of your screen, used for immobilizing long bone fractures of the arm, the leg. And then we have our SAM splint, which is a moldable, so we can mold it into the shape of the limb, and then so that allows us to splint the injured extremity in the position found. So whereas on that padded cardboard splint, you might have had to move the arm and adjust it a little bit. That SAM splint, we can form it up just how we want it, and then form it completely around the injured site. You can also do that with the padded wire ladder, which I don't believe they have a picture in here for you. Soft splints, these are commonly used. The most commonly used are the vacuum splint and inflatable clear plastic air splints. The vacuum splint is going to consist of an inner and outer layer of airtight fabric that is shaped to fit around the arm or leg. There's going to be a skill drill in your book about it. It essentially assess for distal pulse, motor, and sensory functions, while one partner stabilizes, supports the injury. Then you place that splint and wrap it around the limb. And then there's a pump type deal that draws the air out of the splint through suction, seals, and forms around that injured site. Once again, afterwards, we're going to assess for the distal pulse, motor, and sensory functions. Air splints are constructed of a clear, flexible plastic material. Here you can see them applying that. Some of them are zippered like this. You place the arm in there, zip it up, and then you blow into it. You only want to use the air from your mouth to inflate these if you have them on your truck. That way you're not putting too much pressure on it. You don't want to use an air compressor to fill this up. You might put too much pressure on those limbs. Just you always use your mouth if you have these on your truck. The other type, if you don't have a zippered one, it's just a sleeve that rolls up the arm in this case, and you fill it up once again only by mouth. And then checking those sensory pulse and motor functions after we get it set. All right, our traction splints. These are for our lower extremities, generally of a femur fracture. It's not for our tibia or fibia fractures. It's just for those femur fractures. It's going to hold that fracture in alignment by applying a constant and steady pull on the extremity. So it takes a little bit of time to set up. You need more than one person, but you get it all set up. You start pulling traction on that, and it'll pull that long bone into alignment with the other one. Generally helps. It provides quite a bit of relief to the patient when applied. Like I said, it takes 2 trained emergency medical technicians to do it. And depending on your protocols and what your medical director says, You guys might have them on your vehicle, so it's not always just EMTs. Shoulder girdle injuries. The easiest way to splint shoulder injuries is going to be a sling and swath. This is going to be triangle bandages or torn up sheets, whatever you got. It secures it to the patient's body. It holds the arm and then secures it to the body so it's not swinging around. This is the sling is on the left here. Like I said, it holds and cradles that arm, and then the swath is that piece that's going around her chest and arm. That's going to keep it from moving about when we have to move her. Now, with the shoulder dislocation, these are going to be the injuries that are most difficult, the shoulder injuries that are most difficult to mobilize with a sling and swath. Because there's a space, because that shoulder is dislocated, there's now space between the arm and the chest. So you can't bring your arm tight to your chest. What we do is we put a rolled blanket in that space and then apply the sling and swath as we did for the other one. Remember to always check for pulse, motor, and sensory functions before and after doing it. With our elbow injuries, we do not want to move an injured elbow from the position in which you find it. We do not want to straighten that elbow if we have somebody complaining of this, okay? Leave it in the position we find it. Just try straightening it. Can cause nerve, blood vessel damage under there. It's not good. So, splinting it, we'll wrap that elbow in a pillow, add padding, secure the pillow. Then we can gently, as long as there's no pain, move that splinted injury towards the patient's side for comfort and ease of transport. We want to transport them in a sitting position with the splinted elbow resting on his or her lap. All right, forearm injuries. We can use the air splint, like we talked about, that cardboard splint, SAM splint. If we don't have any of that, we can use rolled newspapers and magazines. We can form it around that forearm, make it a nice, stiff splint, tie it to it, we're good to go. You've seen in like movies where they're using sticks and stuff to form a splint to hold it in place. So a couple skills with the SAM splint, you roll it out, you make a little place for the hand to hold, run that SAM splint up past the elbow, because remember we want to splint in front of and below the injured site. Then we secure that SAM splint with gauze to the arm. The zippered air splint, unzip it, put the arm in, check for PMS, blow it up, check for PMS. And then with the unzippered air splint, once again, you slide it over their arm, check for PMS, blow it up, check for PMS. Remember, the only way to inflate those air splints is by mouth. Don't use any other air source for that. All right, our hand, wrist, and finger injuries. We want to use a bulky hand dressing and a short splint. We want to make sure that we cover any wounds with dry, sterile dressing. Place the hand into the position of function. So if you're just holding your hand out, however it rests is your position of function. We're going to place a soft roller dressing into the palm and always apply a splint, secure it with soft roller bandage. So making sure just hold that hand in the position of function and then secure it. Always checking for PMS. That might be, I keep saying it, so it might be a big issue that you might see. If we do have any amputated parts, we want to go ahead and place those in a sealed plastic bag, send them to the hospital with them. They might be able to reattach them. Remember, we want to keep those parts cool. Don't put them directly on ice. All right, pelvic fractures. So with pelvic fractures, there can be a severe loss of blood because those broken bones can easily lacerate large blood vessels that run through your pelvis there. We want to be treating those patients for shock, but we do not want to raise the legs until the patient is on a backboard. So with these patients, if they start exhibiting signs of shock, we need to be sure to be treating that because they could be losing a large amount of blood in that pelvis. When we check the pelvis, we want to feel for tenderness. We want to use both hands to firmly compress on the patient's pelvis. We want to push in on the pubic symphysis, which is those points up high on your pelvis. And then we want to push in from the side on that iliac crest. When we're doing that, a very good sign of pelvic fracture is tenderness when you're doing that, okay? Hip injuries. Dislocations and fractures are most common. Both may result from high energy trauma. Fractures occur in elderly persons because the bone weakens and becomes more fragile with age. They get osteoporosis. We need to immobilize the hip in the position found. We might use several pillows and blankets. And then we need to place the patient on a long backboard. If you remember in that picture earlier with the lady in the car, she got in the car wreck, she struck her knee. That's that indirect impact, the direct impact on her knee caused the indirect injury to her hip when it knocked it out of place. Fracture usually occurs at the upper end of the femur. So where that femur is connecting to the hip joint, it usually occurs to the upper end of the femur, not necessarily the hip joint itself. All right. Thigh injuries. Fractured femur is very unstable. It's going to look like a rubber band. It's not, when you lose that structure under the thigh, it's just complete rubber mess. We need to place the patient in a comfortable position. Once again, these kind of injuries can produce a lot of blood loss, so we need to treat for shock, call for additional personnel and equipment. Like I said earlier about the traction splints, these are the best way to splint a unilateral femur fracture. There's some skills in skill drill 15-6, shows us how to apply a hair traction splint. Hair is just the manufacturer's name. This is not a good picture of it. It does show you how to pull traction here on that thigh. So you're going to want to straighten out that thigh, that leg there, and then you start pulling back on it. When you see the one in your book, you can see that they're pulling, they're placing a apparatus under the thigh and then pulling on it, and then they adjust it and it holds it in place like that. You may or may not have those types of that type of equipment on your vehicle as an EMR. Knee injuries. So exact same as with elbow injuries. We want to immobilize that injury in the position that it's found. We don't want to be cranking on, pulling on, moving, twisting, doing anything with that knee, with that joint. If the knee is straight, we can use a long padded board splints or long leg air splint. If we note significant injury, we want to place pillows, blankets, or clothing beneath that knee, help stabilize it, support it a bit, and then we want to secure the splint materials, whatever we placed under there, to the leg with bandages, swaths, or cravats. We then secure the injured leg to the uninjured leg. This creates somewhat of a stable platform in which we can move them, and then we place that patient on the backboard, remembering to always check for PMS that pulse motor sensory function in the distal extremity after we place a splint. Ooh, sorry about that. Leg injuries. Fractures of the leg can sometimes be splinted with air splints, cardboard splints, magazines, and newspapers. Follow skills in steps and skill drill 15-7 to apply an air splint. So once again, it's just like the arm splint. The one in the drill is a zippered one. Place the leg in there, zip it up, blow it up using your mouth. Ankle and foot injuries. So these fractures can be splinted with either a pillow or an air splint. So you take a pillow and you need to form it around that foot. Okay. Then we're going to tie it or pin it in place. There's a skill drill, just like I just said. We're going to place it in there, form it around that foot, mold it around that foot, secure it with cravats, swaths, bandages, whatever we got, and then we're going to check for pulse capillary refill and sensation down there. We need to practice splinting until we can do it quickly and competently. You might not see these all the time, so it's important that we know how to do it when the time comes. It takes 2 people to splint most limb injuries adequately. One person's going to stabilize and support the extremity, and the other one's going to apply the splint. That goes for just about every one of these that we just talked about. We can do some of them on our own, but like those long bone fractures, we need somebody to hold and stabilize that limb until we can get it splinted correctly. So injuries to the skull, to the head. This is the skull and the brain. So head and spinal cord injuries are common causes of death. They can also lead to irreversible paralysis, permanent brain damage. Our human skull has 2 primary parts: the cranium, which is made up of 4 bones, kind of forms a shell, protects the brain, and then the facial bones, which give form to the face and furnish frontal protection of the brain. So here we can see that whole makeup of the skull. There's 4 bones that are making up the cranium, and then we have all those facial bones. Injuries to the head, MOI, mechanism of injury. It's important to remember that between the skull and the brain, we have that cerebral spinal fluid, and this cushions the brain in there. A direct force, so directly striking the windshield in an accident, getting hit in the head with a hammer or a baseball bat. These are direct forces. These can injure the skull and the brain. An indirect force, so after we've been in that car accident, we were strained, we didn't have a direct force on our brain, but the whiplash, the movement has come of our head rocking back and forth quickly has caused that brain to shift around in there, bounce around inside the skull. We got a couple different types of head injuries. Closed head injury. This is where bleeding and swelling within the skull increases pressure on the brain. This can lead to brain damage and death. An open head injury. These are usually going to bleed profusely because there's lots of vasculature in the head. We need to examine the nose, eyes, and the wound itself, see if there's any blood or cerebral spinal fluid seeping out. At times, brain tissue or bone might be visible. It's important to remember that if there is a head injury, there is a great possibility of spinal injury as well, which means that if we suspect a head injury, we need to suspect injury to the neck and spinal cord, which means we need to be taking our spinal precautions and protecting that C-spine when we come across these patients. Here we can see that brain bouncing around inside the skull there. It also shows in that left-hand picture that we're getting damage to the spine as well. Some signs and symptoms of head injury. We're going to have confusion, unusual behavior, unconsciousness, nausea, vomiting, blood from an ear, decreasing consciousness, unequal pupils. So these are all, if you notice, these are all depressed. So the attitude of the patient would be more depressed, more they're not hyper, they're not agitated. These are a lot of lower functions. They're sleepy, they're tired, they're unconscious. Just remember that. Might also see paralysis, seizures, external head damage trauma, so bleeding, bumps, and bruises. A serious injury may produce raccoon eyes. These are going to look like black eyes. Or battle signs. Battle signs is going to be bruising behind one or both ears. Both of these signs are caused by fractures to internal parts of the skull. So you wouldn't be able to see the fracture or really feel it, but you'll note those signs, and that'll give you an idea that something bad's going on. Here you can see the raccoon eyes on the left, and then that bruising behind the ear is the battle sign. All right, so our treatment of head injuries. Remember, with a head injury, there's also the possibility of spinal injury, so we're going to mobilize the head in a neutral position. Go over our ABCs. We're going to maintain an open airway with the jaw thrust maneuver because we're suspecting trauma. We don't want to be using the head tilt chin lift because that's going to cause a cranking on the neck, and we don't want that. We need to support the patient's breathing with oxygen, and we need to monitor circulation. We need to be prepared to perform CPR if necessary. We need to determine whether blood or cerebral spinal fluid is seeping from a wound or from the nose or ears. So if we look in the nose, the ears, and we see clear fluid leaking out, we need to note that. We need to let the responding agency know about it, but we don't want to stop that up. We don't want to put tissues or rags or dressings in the ears or up the nose to stop that. Remember, we talked about that the brain is swelling, and that can cause issues. Well, letting that bleed out, come out, is kind of relieving some of that pressure. We need to control bleeding from all head wounds with dry sterile dressings. We talked about this before. Remember, when we're doing that, we want to use enough pressure to control that bleeding. We don't want to disturb any of the underlying tissues or structures. We don't want to be poking broken parts of the skull into the mushy parts of the brain, causing more damage. And then we need to arrange for prompt transport when we have these patients. After addressing these, then we'll move on to addressing other serious injuries. Facial injuries. Common result from motor vehicle crashes, when a patient's face hits the windshield, steering wheel. Assaults, people getting punched in the face, or falls. Old people, they just can't get their arms out in front of themselves to stop them when they fall, and sometimes they just fall flat on their face, and it causes major issues. With these injuries, airway obstruction is going to be our primary danger. We're going to have broken nose, broken teeth, broken bones of the skull and the face. These are all, we're going to have lots of blood. These are all issues that can cause problems with our airway. We need to make sure that we're treating our ABCs to keep that from causing an airway obstruction. Just like we talked about with skull injuries, head injuries, we suspect spinal injuries. So we need to immobilize the head in that neutral position, maintain our open airway with the jaw thrust maneuver. We need to help support their breathing. We need to monitor circulation, control bleeding by covering any wound with a dry sterile dressing and applying direct pressure. Now that doesn't mean that we want to go shoving stuff into people's mouths or noses which would further obstruct their airway to stop that bleeding. If we have major bleeding in the mouth, in the nose, in that structure somewhere, we need to keep it clear using suction, sweeping it with our finger if we have to. If all else fails, we can get that patient on a backboard, turn the backboard on its side so that the fluids run out. When we do this, we need to make sure that we're supporting that head. After we get that taken care of, we need to look for and stabilize any other serious injuries, and once again, arrange for prompt transport. So like I said before, if the suctioning, the clearing of the airway, all that doesn't give you a constant, maintained airway, we can log roll them. Once again, making sure to support that neck when we do so. MOIs, these injuries to the spine, mechanism of injuries, can cause a displaced vertebra, swelling, or bleeding. That might put pressure on that spinal cord and damage it. In severe cases, that spinal cord may be severed. And remember, if it is severed, that's going to cause interruption of the signals going from the brain to the body and from the body to the brain. So we could have serious issues with this. It can cause, if it's high enough up in the neck, we can see paralysis of the diaphragm, which if the diaphragm's not moving, we're not breathing. It's going to result in death. Gunshot wounds to the chest and abdomen may produce spinal cord injury at that level. So somebody gets shot in the chest or abdomen, there's a possibility that that shrapnel from bone, from the bullet, can cause damage to that spinal column. Falls, motor vehicle crashes, and stabbings are other common mechanisms of injury. We need to suspect a spinal injury if the patient has sustained a high energy trauma. And in that case, we need to be supporting that spine, that cervical collar, getting it set up. When we see these kinds of injuries, when we see these kinds of high energy trauma, we need to make sure that we position ourselves so that the patient can see us, doesn't have to twist their neck in order to get us in their field of view. Some signs and symptoms of spinal cord injury. We're going to have laceration, bruise, or other signs of injury to the head, neck, or spine. Tenderness over any point on the spine or neck. Pain in the neck or spine, or pain radiating to an extremity. Extremity weakness, numbness, paralysis, or loss of movement. Loss of sensation or movement or tingling, burning sensation in any of the part of the body below the neck. Loss of bowel or bladder control. Our treatment is going to be to place the head and neck in a neutral position. Once again, with any suspected head or neck trauma, we're going to maintain that C-spine, make sure that the head and neck are in a neutral position. We're going to stabilize the head, prevent movement of the neck. Maintain an open airway with the jaw thrust maneuver. Once again, we use the jaw thrust maneuver because it doesn't put any stress on the neck. We need to support the patient's breathing by administering oxygen and keeping the airway open. So if we have that spinal cord injury that has paralyzed some or all of the respiratory muscles, which results in either the diaphragm not moving or other abnormal breathing patterns, we need to be providing that patient, we need to be breathing for that patient. So, and keeping that airway open. We need to monitor their circulation, because if they're not moving that air, they're not getting good perfusion in their extremities. So we also need to assess the pulse, movement, and sensation in all extremities. We're going to examine and treat other serious injuries, mobilize that patient on a long or short backboard, arrange for prompt transport. Stabilizing the cervical spine, skill in 15-9. This is just holding that C-spine, keeping it in a neutral position, and then it also shows us the jaw thrust maneuver, where we're stable, we're forming a base with our thumbs along the side of the jaw there, and then lifting up from the back. That's going to open that airway up. So when we have our motorcycle incidents or our sports incidents where somebody's wearing a helmet, football games, hockey games, baseball maybe if they were batting, any game, anything where the patient's wearing a helmet, usually they do not need to be removed. There are a couple of circumstances where they do. If that face mask or visor interferes with the adequate ventilation and your ability to restore an adequate airway. If it's causing us problems where we cannot get to that airway, we cannot make sure it's maintained properly, and also provide ventilations if they need it, that helmet needs to come off. The other case is when the helmet is so loose, it probably wasn't doing any good in the first place, except for it protected any major damage to the skull. And securing it to the spinal immobilization device will not provide adequate immobilization of the head. So if the head's flopping around in there and you're not able to keep that head from moving when you're wanting to keep that neutral and inline position, if that's the case, then we need to remove that helmet. There's a skill drill on removing the mask on a sports helmet. So if we have a sports helmet that just has a mask on it, usually you can remove screws or cut the retaining clips that hold that face mask in place, and we'll be able to access the airway and provide ventilations for them. If we need to remove the helmet, we want to have one person has to kind of reach up in there inside the helmet from the bottom and hold that head and jaw in place while someone else gently slips that helmet off. As we're sliding that helmet off, the person who's holding the head will kind of slowly move up and continue holding that head until we can get the helmet completely off. All right, fractures of the rib. So even a simple fracture can produce pain at the site and cause difficult breathing. Might be so intense the patient cannot get a good breath, feels like they're not getting enough oxygen. Remember that rib fractures may also be associated with injury to the underlying organs. Remember those ribs are there to protect those thoracic organs. Any injury to those can cause injury to those organs as well. To determine whether a rib is bruised or broken, just apply a little pressure. Note the response from your patient. We need to be alert for signs and symptoms of internal injury, particularly shock. So if we do have something damaged under there, it's causing massive bleeding, something like that, we need to be keeping an eye out for that. We need to note that the patient is not perfusing correctly. They're not getting good blood flow through their body, so we need to keep an eye out for that shock. We're just going to place a pillow against the injured ribs to splint them. There's not a whole lot you can do for ribs. We want to prevent excessive movement, administer oxygen if it's available. Another type of rib injury would be what's called a flailed chest. This is when 3 or more ribs are broken in at least 2 places, and the injured portion of that chest wall does not move with the rest of the body. So our patient's reporting chest pain in their chest or injury to their chest, difficulty breathing, whatever. We expose the chest, and as we're watching them breathe, they breathe in, their chest expands, but that flail segment seems like it's sinking in. And when they exhale and the chest lowers, it looks like the flailed segment is bulging out. That's what a flailed segment is, a flailed chest. It does decrease the amount of oxygen and carbon dioxide exchanged in the lungs. So it might be helpful to, if you note this, the treatment for it is to be providing positive pressure ventilations. So if we see that, we want to go ahead, get them on the bag valve mask, supplemental oxygen, support that patient's breathing. We don't want to restrict the movement of the chest if the patient is having difficulty breathing, so we don't want to put anything on it. Used to be you placed sandbags on their chest, and then they said you put a bulky dressing on it. You do not want to do anything like that. We don't want to restrict it. Like I said, the treatment is good positive pressure ventilations from that bag valve mask. We want to monitor and support the patient's ABCs and arrange for prompt transport. Just keeping an eye on them, making sure that they're getting good, adequate oxygen, and then getting them transported. Penetrating chest wounds. So if an object penetrates the chest wall, air and blood will escape into the space between the lungs and the chest wall. So there's a space between the inside of the chest wall and where the lungs are. It's called the pleural space. If something penetrates the chest, there's a possibility of air and blood getting into that space, which causes that lung to collapse. Okay? And if that lung collapses, it's obviously not doing its job anymore, and now we're not getting good oxygen and carbon dioxide exchange, which can result in shock or death because we're not perfusing correctly. So there you go. Blood loss into the chest can produce shock. What we do is we're going to quickly seal that wound with an occlusive dressing. Remember, an occlusive dressing is a good airtight seal that goes over that wound. Okay, this could be plastic bag, aluminum foil, a glove, whatever it is, something that we can seal on all the sides and provide a good seal. We need to administer oxygen if it's available. We don't want to remove any impaled objects, and we need to arrange for prompt transport. If that patient starts experiencing difficulty breathing, it's possible that you need to lift one side of that dressing and see if the breathing improves. That you might need to let some air out of there because that air is just building up inside that pleural space, and now we need to let some of it out. So we just open it up, it lets the air out, and then we're going to put it back down. Okay, just keep an eye out for signs of difficulty breathing in these patients. All right, so quick summary. Musculoskeletal injuries are caused by 3 types of MOI: direct force, indirect force, and twisting force. Remember, fractures can be closed, where the bone is broken and there's no break in the skin, or open, the bone is broken and the overlying skin is lacerated, which is giving access to dirt and bacteria to get in there and get infected. A dislocation is when we tear the supporting ligaments of a joint. A sprain is when a joint injury caused by excessive stretching of the supporting ligaments. We have 3 basic types of splints. They're going to be rigid, soft, and traction. Closed head injury, bleeding and swelling within the skull may increase pressure on the brain. It's going to cause brain damage. Usually and in an open head injury, there's going to be a lot of bleeding because of all the vasculature up there. Because remember, our brain likes lots of good oxygen, so that means it needs lots of blood flowing through there. So there's lots of vasculature up there that provides blood. Remember that airway obstruction is the primary danger in severe facial injuries. If we suspect a spinal injury, we don't want to move the patient during the examination unless we're in imminent danger. We also need to be supporting that cervical spine by holding their head in the neutral inline position. Most common chest injuries are going to be rib fractures, flail chests, and penetrating wounds. Real quick review. Musculoskeletal system. This is it the involuntary muscles of the nervous system, the connective tissue that supports the skeleton, the bones and voluntary muscles of the body, or the nervous system's control over the muscles. So remember, our musculoskeletal system is going to be our bones. There, it's right there in the name, skeletal, musculoskeletal, and the muscles that we control, which are the voluntary muscles. Remember, involuntary muscles are muscles that we have no control over. So this is going to be C, bones and voluntary muscles of the body. All right, when examining an injured extremity, you should be sure to manipulate it in different directions to determine where the fractures might exist. Keep it elevated at all times. Splint it to reduce movement before conducting any assessments. Or squeeze the entire limb starting from the top in a systematic, firm manner. So remember, it's asking about examining an injured extremity. We do not want to manipulate it in different directions. We don't need to be twisting it, moving it, cutting up internal structures, or possibly causing this closed fracture to become an open fracture when it penetrates through the skin. We don't need to keep it elevated at all times because remember, that's just moving it around some more. Splint it to reduce movement before conducting any assessments. Remember, we need to do an assessment before we splint it. We got to figure out what's wrong before we treat it. So remember that when we're examining and assessing that limb, we're going to squeeze the entire limb starting from the top in a systematic, firm manner. And then we're also going to check the other side. So the answer on this one's going to be D. All right, number 3. Facial injuries should be identified and treated as soon as possible because bleeding is more obvious in the face, patients are always concerned about their face, the swelling may mask hidden injuries, or the risk of airway problems. So while bleeding can be more obvious on the face, and there's probably going to be a lot of it, that's not necessarily why we're treating it as soon as possible. Yes, patients are always concerned about their face, but in the EMS world, remember, we generally say life over limb. We have to save the life. We need to be taking, and there's something else that's going on here that we have to be concerned about. Swelling may mask hidden injuries. It might, but remember, when we're doing our primary assessment and taking care of things in that primary assessment, ABCs all the time. If there's a life threats first, then ABCs. So on this one, we're going to have that risk of airway problems. Boom. All right, guys, that was chapter 15 of our EMR course. Only a few more to go, and we'll be ready to get you tested and get you on the truck as EMRs. We'll see you on the next one. Later.